you very much for the very kind introduction, and particularly for giving me the opportunity to introduce the Harvard Brain Tissue Resource Center and our collaboration with the Cohen Veteran Bioscience, and to speak and discuss a little bit about the work we do at the Harvard Brain Bank, as we affectionately call it. I will first provide an overview, including a brief introduction of the Harvard Brain Tissue Resource Center and its history. I will briefly discuss why postmortem human studies are important, although I'm sure that the audience already agrees to much of that. I will go over our workflow, particularly not only current practices, but also some of the challenges and some of the ongoing enhancement and efforts to address them. And particularly, I will discuss outreach efforts in efforts to increase the awareness of the importance of brain donation. I will go over how to register to become a brain donor, and as well as how a brain donation happens, tissue processing, distribution, quality control, and neuropathology, and as well as the work we do to obtain and analyze clinical and demographic information about brain donor. And finally, a plea to all of us to help us in these endeavors. The Harvard Brain Tissue Resource Center is a national resource for the collection and distribution of human brain specimens for research. It has collected over the years over 9,000 human brain specimens from a variety of neurological and psychiatric disorders, as well as from healthy controls. We have approximately 30,000 potential donors that have registered over the years. And we are organized to collect brain donation from across the country with a postmortem time interval of 24 hours or less, and we will discuss how that is actually done. And again, we distribute brain samples to research groups, not only within the US, but across the world. A brief history of our brain bank. The brain bank was founded in 1978. And the first director was Dr. Edward Bird. It was established at McLean Hospital thanks to the efforts of Dr. Pope and Dr. Mataisi, who recruited Dr. Bird, who had previously built a brain bank in the UK, to become the first director. In 1995, Dr. Francine Benes became the director, and Dr. Bennett broadly expanded the reach of the Harvard Brain Tissue Resource Center, organized it in the way I will describe, in a way that it can receive and send out samples from across the country. She also made a particular effort to keep up with technological advances and transition the Harvard Brain Tissue Resource Center into the Neurobiobank group, which I will mention in a couple of slides. In late 2014, Dr. Bennett stepped down, and Dr. Wilson Wu as the medical director and myself as the scientific director took over. We are working to still expand our efforts for brain donation awareness, actively working with other brain banks within the Neurobiobank group, as well as establishing new collaborations and bringing keeping up with the technological and also clinical advances in order to continue service brain research. In 2013, the Harvard Brain Tissue Resource Center became part of the NIH Neurobiobank, which is supported by the National Institute of Mental Health, the National Institute of Neurological Disorders and Stroke, and the Eunice Kennedy Shriver National Institute of Child Health and Human Development. In addition to us, several prestigious brain banks, such as the University of Maryland, the Miami Brain Endowment Bank, the Human Brain and Spinal Fluid Resource Center run by the Sepulveda Research Corporation, the University of Pittsburgh and Mount Sinai join us in these endeavors. Finally, in early 2016, a partnership was forged between the Cohen Veteran Bioscience and the Harvard Brain Tissue Resource Center. From this collaboration, the Cohen Brain Collection was born, dedicated to collecting and making available to researchers specimens from people that have been exposed to trauma. Why is this partnership important? If we look at postmortem human studies within the last 60 years, we realize that many thousands of papers have been published on disorders such as schizophrenia, Alzheimer's disease, and Parkinson, with, as opposed to only 26 on post-traumatic stress disorder. This creates a significant obstacle in understanding this disorder. The addition of human postmortem studies is essential to understand this complex disorder, which need to be studied by complementary methodologies that look at the genetics, adopt in vitro iPS cells and other in vitro approaches, animal model, clinical studies, human brain imaging, in addition to human postmortem studies to really understand this disorder. The contribution of studies on postmortem human brain is that the studies allow unique access to the molecular and cellular changes that occur in the brain of people that have been exposed to severe stress. For instance, gene expression, protein expression, cell protein expression and morphology, changes in synapses and as well as infrastructure can only be investigated by using human postmortem brain. A little bit more about the Harvard Brain Tissue Resource Center. As I mentioned, we are able to accept brain donations from all over the country. This is, for instance, the number of brains that have been collected over a 10-year period from each state and arrived at our brain bank. And on the right, you see the number of samples that have been distributed to each state as well as internationally. These have been distributed to a large number of research groups working on a variety of neurological and psychiatric disorders. We accept diagnoses, a variety of diagnoses, as well as normal controls, which are particularly precious to all investigations, not only to provide more information on the human brain, but also as comparison group, we're trying to understand what changes occur in the brain of people affected by brain disorders. We also collect a variety of psychiatric disorders, as you see listed here, neurological disorders, neurodevelopmental disorders, and we are fortunate to collaborate with several foundations, including the Tourette Association, the Dystonia Medical Research Foundation, the RettSyndrome.org, together with CDKL5 Research, the 401Q MECP2 duplication syndrome, and the International FOXG1 Foundation, as well as the Restless Syndrome Foundation, and particularly the Cohen Brain Collection, which I have mentioned already. This is the workflow that we use. Outreach programs, as I will discuss, are of particular importance in our ability to collect brain donations. We hold a registry of potential brain donors, and we have an on-call team 24/7 for donation coordination, as I will describe. This team will discuss brain donation with the family at the time we are called, process and informed consent from the legal next of kin. We have several secure electronic transfer methods that allow us to obtain consent remotely and securely. We coordinate with the pathologist for the brain removal, and we have a network of pathologists that can do this across the country, and a courier for the transport of the brain specimens to the brain bank. There we have a team of dissectionists that are on call 24/7 and are ready to process the brain, store it both frozen and fixed, as we will discuss. What happens next is a series of quality control and neuropathology, as well as collection of an analysis of clinical and demographic information on the donor. Finally, we distribute tissue to investigator upon evaluation of each tissue request. As I mentioned, raising awareness of the importance of brain donation is particularly important. Without them, it will not be possible to reach all communities and to all potential donors, and therefore obtain these very precious specimens. These efforts are directed typically to several groups, including clinicians and social workers, as well as obviously potential donors, their families, and advocacy groups. It is essential that we all emphasize the importance of brain donations from people that are not affected to brain disorders, what are typically called healthy controls, for the reason I mentioned, not only because we don't know enough about the human brain from many point of view, molecularly, cellularly, and as connectivity, but also because it is critical to be able to compare brains from people that had a brain disorder to healthy controls. It is also important to emphasize that awareness is strong of the importance of brain donation, is strong for certain disorders, such as neurological disorders such as Huntington or Parkinson and Alzheimer, as well as some psychiatric disorders. However, less has been done until recently to raise awareness of the importance of brain donation for other disorders and PTSD in particular. So much of our efforts at the moment are dedicated to address this particular issue. Here is quickly how one can register to become a brain donor. It is actually an easy process. Any person 18 years of age and older can contact us at the number you see on the screen, or can obtain a registration form from our website, and for people that have been exposed to trauma, from the Cohen Brain Collection website. These forms can be mailed or faxed to us. The importance of registration is in particular to discuss a decision to become a brain donor with the family, and make sure that the family knows that it is important to call us immediately at the time of death, or even just before, if it is possible. We do not actively reach out to people, so we need to rely on a collaboration between the family and us to know when it is time for a brain donation. A registration, however, is not needed to proceed for a brain donation. We can be called at any time. It's just a very good way to discuss this with family and caretakers. At the time of death of a potential donor, it will be up to the family to reach out to us, discuss the brain donation, sign and inform legal consent, and eventually proceed with the brain donation. However, a registration, if done, can be withdrawn at any time by writing to us and is not binding. Apologies. For more information about registering, please consult our website or call us anytime during office hour to discuss this process. How does the brain donation actually work? The main difficulty is that it has to be completed within 24 hours or less if possible. And this is counted from the time of the donor's death to the time the brain is received at our facility, dissected and stored, what we call postmortem time interval. The first step is the first step is to call us, and I would like to introduce our staff who accomplishes this feat within such a short time. George Tejada, who is our Assistant Director of Operations, as well as takes care of donation coordination, dissections, and as well as tissue distribution. A set of people that do both the donation coordination and are dissectionists. Our senior clinical liaison, Kay Sullivan, our main donation coordinator, Joseph Manzo, and some of our dissectionists and donation coordinators, such as Fadia Madi, Sayad Bukhari, and Katina Athanas. In addition, we are lucky to work with Dr. Hedrin, who is our Associate Director and Neuropathologist, as well as Tim Wheelock, our histologist. We have a complex database, so Dr. Enulat helps us with that, and we wouldn't be able to do without our administrative assistant, Julie Janjania, who also takes care of registrations. The first step toward a brain donation is brain donation coordination. Our staff will take calls from the brain donor family at any time, 24/7. And as I said, obtains a legal consent, arranges for a pathologist to remove the brain, coordinates with airlines and ground carrier to finally have the brain reach the brain, the Harvard Brain Bank. This is our dissection room where the brain arrives. It is received fresh, packed with ice, and at that time is weighted, examined, photographed, and dissected and finally stored. So the third step is our brain dissection. We separate the two hemispheres. We also receive not only brain, but also cerebral spinal fluid, blood, and dura mater, in some cases spinal cords. The two hemispheres are, one will be frozen, the other will be fixed and also processed for neuropathology. The hemisphere to be frozen is cut in coronal slices according to specific landmarks and in sections, in thick sections, as you see them, which will then further dissected before getting frozen. Frozen specimens are stored in freezers at -80 degrees. Our neuropathologist, Dr. Redrin, will examine the brain, the hemisphere that was fixed, first the exterior of the half brain, in this case it was the left, and then slice it from back to front in order to examine the interior of the brain. A photo you see on the right. Samples will be taken from 15 different brain areas, sometimes more if it is necessary for pathology report, and they will be embedded in paraffin, sliced, and then eventually stained with an array of histological and immunocytochemical protocols. And you see examples here, as well as here, in which you see photographs of typical findings in different pathologies, such as senile plaques, neurofibrillary tangles, amyloid angiopathy, and reactive gliosis, as one would detect it in Huntington disease. And these are just some examples of different disorders and how they might look like. For instance, at the top right, you see a brain of a healthy control, while to the left, you see the brain of somebody with Alzheimer's disorder. An example of Huntington disease, the photographs on the bottom left, the most left with the arrow is from Huntington. You can see severe loss of brain matter, both in the corputamen and in the cortex, with comparison to the half section you see on the right. And finally, on the set of photos on your bottom right, you see the brain of Parkinson's disease marked by the arrow. As compared to a control, you see loss of the substantia nigra is the strip pointed in the control brain by a thin brain red arrow. Finally, it is important to emphasize that the brain donation is a collaboration between the brain donors, their families, and the Harvard Brain Tissue Resource Center. A potential brain donor may wish to register and discuss with us and with their family their decision to become a brain donor. They can contact us anytime to discuss following registration, to discuss the process and any concerns or questions. We collaborate with the family when they contact us immediately before or at the time of death and work with us to carry out the informed consent. Finally, after a successful brain donation, we collaborate with the family in order to obtain as much information as we can from the donor, such as medical records and questionnaires that the family fills for us. These are essential in order to understand as much as we can about the brain donor, the disorders that the brain donor may have had, and any other possible information that might help us understand the results from investigations. Finally, we provide to the legal next of kin a full neuropathological report, which is issued by Dr. Green. The family can also, the legal next of kin can also request that the neuropathological report is also sent to other family members, as well as a treating clinician if they wish. So how does how a brain donation contribute to research on brain disorders? As I said, investigators from across the world can request brain tissue for their research. Depending on which brain disorder they are interested, they can address their request to the NIH Neurobiobank or directly to any relevant foundation. We are available to discuss requests with investigators to prepare ahead of a formal application for tissue. And we are able to provide a frozen, fixed, and paraffin-embedded tissue to investigators. Thousands of original manuscripts have been published over the years reporting on findings on the human brain in a variety of neurological and psychiatric disorders made possible by the generosity of brain donors and their families. A few key considerations on the use of brain specimens for research, and something that we are actively working on to continue improve, particularly quality control. We need to screen potential donor at the start of the donation coordination. And this is because we may not be able to accept the brain donation. Our exclusion criteria are postmortem time interval, as we discussed. They may be longer than 24 hours. So if we are contacted too much later after death, we might not be able to accept the brain donation. If the body has not been refrigerated before brain removal, we may not be able to accept it, again, because the brain tissue may have deteriorated. We're not able to accept brain donation with known or suspected infectious diseases such as HIV, hepatitis, and Creutzfeldt-Jakob disease. In some cases, and this will actually be evaluated case by case, a penetrating trauma to the head of a massive stroke before donation may be a criteria for exclusion. In order to keep the quality of the specimens as high as we can. We carry out a brain dissection immediately upon arrival, again to keep the postmortem time interval as short as we can. As I mentioned, we have a team of brain dissectionists on call 24/7, so they often come at 3 o'clock at night to dissect the brain. The brain samples are quickly frozen in liquid nitrogen vapors, and all precautions are taken to preserve RNA integrity. We measure both the pH and RNA integrity number for all our specimens. We do serology and toxicology screening. And as I mentioned, we issue a full neuropathology report for all specimens. It is also important to understand as much as possible, as I mentioned, about each brain donor, gathering a diagnostic, demographic, and clinical information on each donor. So we make every effort to recover medical records spanning the course of the disease. And again, we need the help of the family to do that. We gather demographic information, clinical history, family history, and these are extracted from the documents that we have been provided and compiled and made available in an anonymized manner to all investigators. The medication history is assessed on the basis of toxicology screening, careful screening of the medical records, and estimated total exposure to each medicine over lifetime and during the last 3 months of life, something that I will discuss in the next few slides. We also assess substance abuse, both on the basis of toxicology screening, as well as medical records and family questionnaires. And a consensus diagnosis is reached on the basis of this information. Again, I would like to touch upon a couple of important points. One is trying to assess exposure to pharmacological agents which may impact on the findings on these brains, as well as on establishing a full diagnosis. So these are ongoing efforts. So there are issues that are actively discussed in our field, and they are key to understand the results from any postmortem study, as medication history might not only generate some changes, but also in many cases mask potential changes that are related to the disorder. It's work in progress, and any comment and suggestion will naturally be very welcome. We feel that it is important to establish a time framework for exposure to pharmacological agents. One way to think about it is to look at exposure at the time of death, which can be done looking at toxicology results, as well as, of course, medical records. And we find it useful and potentially informative to distinguish between medications that have been given or to the patient 3 months or maybe 6 months before death. This can be done according to medical records and questionnaire or interview with the family, as well as exposure to pharmacological agents, to medicines across lifetime. And I will discuss very briefly why we think that looking at this time frame may be particularly useful. The last 3 to 6 months of life represent a very distinct period from a pharmacological point of view, and this is true particularly for elderly donors or any donor that may have died as a consequence of a systemic disorder. This is because many patients are exposed to several additional medication for systemic disorders, as well as palliative care and pain. Often the medication for the primary disease may have been reduced or discontinued. By primary disease, I'm referring to the brain disorder a brain donor might have had, both neurological or psychiatric. However, although medications for these disorders may have been discontinued, they have often been taken for decades before that, and they are likely to have induced changes that endure even after discontinuation. And we have some evidence that this may be true. This is, for instance, an example from an elderly patient with bipolar disorder. And I would like to draw your attention to the impressive difference in medication strategy 1 year before that, in which three medicines were taken regularly by the patient, in comparison to the 3 months before that, where a very large number of medication were taken by the same patient. The question is that we need to ask ourselves is which one we should account for, and our suggestion is both. It's important to account for all medication taken within the last months before that, as well as medications that were specific for the primary disorder taken chronically. This is an example of why this may be important. In the top graph, you see a correlation between exposure to antipsychotic within the last 6 months of life versus exposure to antipsychotics lifetime. You can see that the correlation is not significant, and really there isn't any, suggesting that looking at this last 6 months of life may not be representative of the actual exposure during lifetime. This is even more impressive for the graph at the bottom, in which you see the exposure to lithium calculated in grams overall within the last 6 months and lifetime. You can see at the bottom within the rectangle that several patients that had been exposed over lifetime to kilograms of lithium as a cumulative assessment are at 0 at 6 months. Again, suggesting that it is important, it is essential to look at both during the last few months before that, because of other medications that may be given to the patient, as well as perhaps during lifetime. The way lifetime exposure is challenging, and yet it can be done. We suggest that it might provide a more accurate estimate of chronic exposure to pharmacological treatment, specifically pertinent to the primary brain disorder. And again, I would like to emphasize that this is key, because exposure to such medications may not only have induced its own changes, but perhaps because it was addressing pathology, may mask changes that are directly related to the disorder. And thus, it is useful for result interpretation as well as for formulating distributive diagnoses on the basis of which pharmacological agents had been, in fact, prescribed for long periods of time and were putatively the most effective. So again, this supports the time frame that I discussed. And so our attempt currently is to use toxicology results and data from medical records and questionnaire to account for this particular time framework. I won't go through too much, but these are examples on how total exposure in grams may be calculated for several medications such as antidepressants, mood stabilizing and anticonvulsants, as well as, of course, lithium antipsychotics. And for medications that are part of a larger family, such as antidepressants and mood stabilizers, they can be calculated as equivalent to a particular drug, such as Imipramine for antidepressants and carbamazepine for mood stabilizers and anticonvulsants. And I would be happy to discuss this more if it is of interest. It is also key to use the best we can the information that we have about our donors in order to formulate not only a diagnosis, but also in keeping up with current trends and thinking about particularly psychiatric disorders, in considering the difference between diagnostic categories and clinical dimensions. This is obviously challenging to do, both with live patients, even more with donors, for which we only have the medical records and interviews and family questionnaires. However, we are attempting to use better the medical records we have. So, for instance, we are collaborating with several clinicians to try to adopt established rating scales to apply them to medical records. So, for instance, the clinical dementia rating might, at least in part, be applied to information that is contained in the medical records, and it would be particularly important to understand cognitive decline in brain donors with several disorders. We are also endeavoring to find ways to use electronic health records together with information retrieval and natural language processing methods to try to extract measurable clinical behavioral dimensions and possibly according to our doc domains and constructs. Finally, and which is a very exciting possibility, we are attempting to use online tests on registered brain donors, and this may be a way to collect information following the course of their disorder, perhaps, or particular aspects of it. Finally, this is how you can help us. As I mentioned, awareness of the importance of brain donation to research on PTSD is truly critical, as well as many other disorders, and yet is sorely lacking. We are hoping that you all as a community will help us by discussing the importance of registering to become a brain donor with colleagues, families, patients, particularly people that have been exposed to trauma. And we would like to remind all of us that the gift of a brain is truly and in a very concrete way a gift of knowledge. Thank you very much for your attention. It was a pleasure to discuss this matter.
Thank you, Dr. Berretta. And if anybody has questions, please type them in the chat box, and I will read them to Dr. Berretta. While I'm waiting, I just wanted to give you a little background on what she and her research team at the Translational Neuroscience Laboratory are doing currently. They're conducting investigations on the pathophysiology of psychiatric disorders. Specifically, human, postmortem, in vitro, and animal model studies are being used to investigate the role of the brain extracellular matrix in normal and abnormal pathologic states. Current studies are aimed at testing hypotheses on abnormalities in molecular composition of the brain extracellular matrix, organized structures, and cell populations affected by these abnormalities. So you can see some interesting research is going on. And as Dr. Berretta said, send your brain to Harvard. And now if we have any questions, I don't see anything coming in right now. We do, I know, have a lot of people online. So if you have questions, please send them in. We'll wait another minute or so. Again, type them in the chat box. Okay, well, if we don't have any questions, just want to thank Dr. Berretta for her time and for a wonderful presentation, and remind everyone that you or your friends or colleagues can view this on the Cohen Veteran Bioscience website and on our YouTube. So if you'd like to follow up and see it afterwards, and I'm sure Dr. Berretta would be happy to take questions by email afterwards. Thank you very much.